Well, thank you, everybody, for joining this webinar. This is the webinar for the Cancer Intervention and Surveillance Modeling Network, or CISNET Incubator Program for New Cancer Sites Pre-Application Webinar. I'm Rocky, formerly Eric, but Rocky Foyer, Chief of the Statistical Research and Applications Branch in the Division of Cancer Control and Population Scientists, and the overall NCI CISNET Project Scientist. Well, first of all, I want to talk a little bit about CISNET in general and what is the CISNET. It's the NCI-sponsored collaborative consortium. It's a U01 grant mechanism of simulation modelers in 6 cancer sites: breast, prostate, colorectal, lung, esophagus, and cervical cancers. It was formed in 2000, although some of the cancer sites joined more recently. And these are funded by competitive grants renewed every 5 years. And RFA-CA-20-043 funded competitive applications. This is for the main CISNET program that just started in September of 2020, and it'll be running through August of 2025. The main purpose of CISNET is to synthesize trial, epidemiologic, and surveillance data using simulation modeling to guide public health research and priorities, and to help address what's sometimes called the formidable and growing gap between the rapid pace of innovation in cancer research and our ability to efficiently harness it to improve population health, and to provide a link between complex evidence and actionable public health strategies. Trials and other direct empirical evidence will never provide all of the answers we need to respond to important public health questions, and CISNET models incorporates relevant direct evidence along with data-driven assumptions to try and fill these gaps. I'm next going to talk about comparative modeling, which is a cornerstone of CISNET, and the consortium organization we've developed to facilitate it. So in many instances, probably many of you know, individual modeling efforts yield different results that are quite difficult to reconcile, and the approach innovated by CISNET is a systematic comparative modeling approach where there's central questions to be addressed by groups collaboratively with a common set of inputs and outputs, where reproducibility across models adds credibility to the results, and differences points out areas for further study in a very systematic way. And probably the most high profile of the work CISNET has done is to assist the U.S. Preventative Services Task Force in developing screening guidelines for colorectal, breast, lung, and cervical cancers. And prior to CISNET, the task force rarely used modeling and relied on direct evidence reviews because it was difficult to know which model to use, and the idea of assembling a group of modelers who had never worked with each other before would be quite cumbersome. So the approach we've used has allowed the task force to feel comfortable using the suite of CISNET models for any particular cancer site to assist them in developing screening guidelines. So in terms of a consortium organization that facilitates comparative modeling, there's 6 cancer sites and 6 multiple PI grants, each focused on a different cancer site with a coordinating center and between 3 and 6 modeling groups. We have quite a large and diverse staff facilitating CISNET work in 2 divisions at NCI, the Division of Cancer Control and Population Sciences and the Division of Cancer Prevention. For each cancer site, we have what's called an NCI project scientist who help facilitate the science interactions between things that are going on scientifically at NCI and your cancer site, and just help in many areas in the scientific realm. Susan Scott, who's sometimes called the Administrative Program Director, helps with various kind of financial and things like that. And she's the Program Director for all of CISNET. And many of these people are on the call today and will serve as panelists to help facilitate answering questions. The framework for CISNET modeling starts with common inputs, risk factor trends, screening behavior, diffusion of new treatments, and then this leads to individual cancer simulation models. This is really the heart of CISNET. As I mentioned before, these are between 3 and 6 independently developed models. We don't want models that are all the same. It doesn't do much good. And we model parallel, unlike real life, we model parallel lives with and without interventions. The modeling generally starts with demographics in early life, sex, race, year of birth, development of risk factors, and then it moves on for preclinical cancer, precancerous lesions, and tumor initiation and growth. Of course, the preclinical natural history disease isn't directly observable, and has to be inferred indirectly from autopsy, screening, and other studies that reveal glimpses of the natural history of disease, and this represents one of the major challenges of CISNET modeling. And then it moves on to post-clinical cancer, diagnosis of cancer, treatment, recurrence, and subsequent treatment. And I highlighted recurrence and subsequent treatment here because towards the end of the last round of funding and then in this new round of funding, it was difficult to model recurrence and subsequent treatment because some of the population-based data sources that we needed didn't exist. But this has been a newer and active area of research within CISNET. I'll say a little bit more about that later. And then death from cancer, other causes. And then summing together individual histories, again, in the presence and absence of interventions, we can model the harms and benefits of interventions, for example, mortality, quality-adjusted life years, overdiagnosis, direct medical costs, etc. And then we add calendar time as appropriate by modeling multiple birth cohorts to represent the real U.S. or other populations over time. This here shows an example of a risk factor generator. This is the lung cancer group smoking history generator. And just to give an example of what a risk factor generator looks like, it was developed using national health interview surveys from 1965 forward and reconstructing the age at initiation of smoking, cigarettes per day, age of smoking cessation for cohorts born between 1890 and 1995, and now they've even projected out into the future. This has been developed by sex, but also by race, income, education, and which state of the country you're in, because many tobacco control interventions are conducted by state and allow them to do that. And of course, you put in an intervention, it modifies either the initiation, cessation probabilities, or other aspects of it, what's in the smoking history generator. So far I've talked about the CISNET program as a whole, and now I'm going to talk about the motivation and purpose of the CISNET Incubator Program specifically. And the motivation starts with that questions that CISNET models can address really extend beyond the 6 current sites. And the idea is to translate CISNET's model success to cancer sites for which there have been nascent or limited population modeling efforts to date, and little to no comparative modeling. And what do we mean by nascent here? Well, in this context, in the context of this funding announcement, it represents models in really a wide range of current states of development, ranging from those in the early conceptual stages to those that have been programmed and undergoing model calibration and validation, to those that have produced published applications but could undergo extensions, expansions, or reconfiguration under this funding announcement. So really models in a wide range of development. Well, what is the state of population modeling in cancer sites beyond the 6 included in CISNET? Well, they're at many different places, but I wanted to do a little bit of generalization. First of all, beyond the 6 cancer sites in general, there's fewer existing models, and they're not as well developed. And then in some sense, because of a lack of consistent funding over time, most are what we call one-off efforts that focus on a single limited portion of the cancer control spectrum. And what do I mean by one-off efforts? Well, perhaps there's a larger grant submitted on a general topic, and one of the aims, they're going to develop a decision analysis model. It's used for one thing, maybe to evaluate treatment, different treatments or something like that. And it's used, and then sometimes after you publish an article or two, then it's not used anymore. We're in CISNET at the exact opposite end, where we have models that we really want to develop across the complete cancer control spectrum, and they'll be used for many, many years. And certainly you could recognize the importance of including synergies across the cancer control spectrum, for example, between screening and treatment advances. There's been, in most cases, no or very limited comparative modeling. Sometimes there's been post-publication comparisons of models and results, but this is difficult to do because of so many things varying simultaneously. And what might make this type of modeling even more feasible now is the availability of many new data resources to inform models. For example, large observational databases and specialized linkages that you'll want to, of course, take advantage of. The incubator program is going to operate on a little bit smaller scale than the main CISNET program. These are multiple PI grants with 2 to 3 as opposed to 3 to 6 independent modeling groups that will share common data sources and compare the models as they're developed. One group will serve as the coordinating center for that cancer site. And while open to all qualified investigators, we really want to encourage broad participation from population modelers in cancer control. So this funding announcement will allow no more than one principal investigator who is funded under CISNET RFA-CA-20-043, that's the currently existing CISNET grant, to also be a principal investigator on each incubator application. Well, what are we looking for? In the past in CISNET, we specified what cancer sites we were looking for specifically. In this application, any cancer site except the ones existing in CISNET could come in, and we're specifying what we're looking for, but not which specific cancer sites. So we want to leave it up to the research community to make the case that a cancer site is amenable to this type of modeling and would have impactful public health benefits. We're looking for cancer site-specific proposals where applicants bring together separate, nascent, independent modeling efforts focusing on important cancer control applications, that data sources exist to inform the models, especially the preclinical natural history disease, if it's applicable, that there's potential interventions or strategies are sufficiently well developed to provide estimates of their operating characteristics. Sometimes people in modeling and in CISNET as well do what-if analyses when we don't know much about the interventions, and those have their place, but the basics really are where we're working on things that are sufficiently developed so we know something about their operating characteristics that we could put into the models. And then priority would be given to applications that propose modeling feasible cancer control opportunities at different points across the cancer control spectrum. So the applicants are expected to generate sophisticated evidence-based decision tools that could inform decisions on the most efficient utilization of existing and emerging technologies and strategies for the control of the proposed cancers. In terms of an overview, each application will cover a single cancer site. Of course, I mentioned cancer sites previously funded under CISNET, the 6 are not eligible. It's NCI's general intent to fund one project per each eligible cancer site. That's any cancer site other than the 6. And you want to put forward a comprehensive program of comparative modeling with coverage across the important cancer control areas and relevant specific priority areas for that selected organ site. And I'll be talking in a minute about what priority areas, what that means. And you, of course, focus on areas of public health relevant impact amenable to modeling for that cancer site, and then take advantage of relevant new results or anticipated new results that would become available during the grant period. Well, what is the definition of a cancer site? When I started writing this RFA, I thought, well, that's kind of obvious. And then I thought, well, maybe it's not that obvious. So I spent some time, and you'll notice in the RFA, I spent considerable time talking about what do we mean here. So the cancer site definition of an incubator application would generally be defined using commonly classified sites, such as groupings found in the SEER site recodes, ICD-03, WHO 2008 definitions, or SEER extent of disease cancer schemas. There's links to those in the RFA. And these lists are defined by combining both topographic and morphology codes using ICD-03. So the selected grouping that you should choose is really a balance among 3, and there's somewhat opposing considerations. Homogeneity, subtypes including the selected grouping should share some common traits, potential population impact, having a reasonably large population footprint in terms of the grouping's morbidity, mortality, or economic burden, and the portion of that burden that might be alleviated by strategic and feasible cancer control interventions, and simplicity through the use of common broad groupings. So here there's quite a bit of flexibility, but you want to justify what you do. So applicants are encouraged to include as many subtypes in the groupings as feasible in order to maximize population impact, but some subtypes that can be excluded if including them would pose excessive challenges scientifically. For example, if modeling one or more subtypes would require an entirely different approach than modeling the more common subtypes. And so you have to justify the selected classification, and you should be explicit about what you're modeling and why you chose that quote-unquote cancer site. Some relevant dates. The letter of intent is due 30 days prior to the application due date. It's not required, but highly desirable, especially to allow time to get the relevant reviewers for your particular application. The application is due January 20th, 2021, and the earliest start date would be around September of 2021. In terms of priority areas, these are areas of focus for the applications. We developed these by discussions with modelers and people in NCI and a whole slew of people. And we have listed here the same priority areas as this round's main RFA for CISNET. But the new incubator site, will spend considerable amount of time on model development and refinement and consideration and study of data sources to inform the models. In the existing main CISNET site, the models came in being quite mature, and so they could get right to applications. In the incubator, we recognize that you'll be spending some time on model development and refinement before you get to these areas of application. And the last of these, called cancer site-specific opportunities, that's the last priority area. And this is meant to be kind of a catch-all, includes opportunities that may exist for cancer site-specific modeling that are critical for that site, but may not fit into the 8 areas above. And for the incubator program, as we thought about it, we wanted to especially emphasize under this what might be called optimizing strategic opportunities in prevention. And while some cancer sites previously funded in CISNET have ongoing prevention modeling efforts, as you would expect, especially lung, colorectal cancer, and cervical cancer, cancer sites beyond those funded sites present many strategic prevention opportunities related to risk factors such as HPV, HIV, H. pylori, hepatitis B, hepatitis C, smoking, excessive alcohol consumption, and perhaps others. And one thing that's important is that only cover those priority areas that are most relevant for your cancer site. There is no need, and it would not be expected to cover all of them. So you're making decisions about which priority areas of application are important to you. I'm not going to go over all the priority areas. I'm just going to go over 2 briefly, and they're kind of newer ones, and you could read about the priority areas in the RFA. And the one I want to talk about is precision treatment. I remember I mentioned that recurrence and salvage therapy are things that they're working on in CISNET, and that's under this area of precision treatment. And that's sort of evolving big data resources from electronic claims, labs, and health records, and their potential linkage to population-based registry data will generate detailed information on first-line and salvage therapy, dose, recurrence, and the genomic characterization of disease. So the types of questions that could be answers, these are just examples. Don't feel limited by these. Population impact of therapies, value-based threshold pricing of new therapies, setting the cost so that the cost-effectiveness ratio is equal to established regimens. When is the genomic characterization of tumors cost-effective? And then trial design and evaluation, considering different endpoints, eligibility criteria, extrapolating long-term outcomes, including quality-adjusted life years. This is especially important in de-escalation or non-inferiority trials, and then simulating the chance of a positive trial result as a function of trial design options. In terms of methods development, CISNET is an application-oriented program. So methods must be directly motivated by applications and then must be applied after development to demonstrate their practical utility. We're not really supporting just general methods development. It should be really applicable to the problems you have at hand. And just some examples. Again, these are just examples. Don't feel limited by these. The role of advanced algorithms in high-performance computing and calibration and probabilistic sensitivity analysis of CISNET models, incorporating statistical models, for example, risk models or models of time to recurrence in the simulation models. Further developments in meta-modeling. This is something that's been done to some extent by CISNET, and that's combining trials using modeling that are too different to combine using standard meta-analysis. And simulation model emulators. These are statistical models which emulate the relationships between CISNET model inputs and outputs, providing simplified ways to make model results available to stakeholders. In terms of the application, the usual application, of course, is, I think, 12 pages. Here it's quite a bit longer because we feel there's a lot to cover. It's 30-page maximum. I'm going to go, the subsection A is overall objectives and significance. B is project leadership and coordination, advisor groups, professional enhancement and model accessibility. C is modeling groups, their models and previous model applications. And D is proposed model development, refinement, consideration of data sources, model validation, model comparisons, model extensions, and applications. I'm going to go through each of these because I think it just helps flesh out what we're looking for. So first is overall objectives and significance. First of all, you want to justify why the selected cancer site fulfills as many of the criteria as possible for inclusion as an incubator site. As described previously, that was back in slide 10, and you could also find it in the RFA. You should talk about the justification for the selected cancer site. In other words, which ICD-03 codes and should be included and why. Indicate the participating modeling groups to be included. You want to state concisely the importance and health relevance of the research described in this application by relating the specific aims to the broad long-term objectives. And if the aims of the application are achieved, how scientific knowledge, public health guidelines, or clinical practice would be advanced. Describe the effect of these studies on the concept, methods, technologies, treatment services, or preventative interventions for the specific cancer site. And then list the broad long-term objectives and the goal of the specific research proposed. The goal should be stated both in terms of the modeling the work that needs to be done and then in terms of the broader healthcare objectives of the modeling exercise. And then a rationale for determining which of the priority areas you decided to address. Next subsection is project leadership and coordination, advisor groups, professional enhancement, and model accessibility. So in terms of the coordinating center, this is the plan. You should plan for and describe in your applications the following coordination activities. And I've had some calls with people, and they sometimes think coordinating center, in the usual context, that means data coordinating center. And really, this coordinating center, there is some coordination of data that's coming into use in the models, but it goes well beyond that. So we really list quite specifically the range of things that this coordinating center will do, really coordinating all the activities and not just a data coordinating center. So in terms of formulating, prioritizing, and coordinating work on base cases, in other words, joint comparative modeling projects, and other questions, including outside requests that may be accommodated within the existing scope of work, or may even represent new funding opportunities. Negotiating common requests for outside data sources. Each group doesn't have to go get data themselves. They could be negotiated in common. Consensus building and coordinating critical evaluation of disparate results. Preparing inputs and collecting and processing common outputs for model comparisons. Coordinating synthesis papers and group responses, bringing together disparate information to inform policymakers. And coordinating review of new and relevant literature and inviting guests to meetings and vetting of proposed affiliate members. I'll talk in a little bit what we mean by affiliate members. And then organizing conference calls and setting meeting agendas. In terms of leadership, this is a multiple PI application. Generally, it would be one PI for each modeling group, and generally the contact PI is the coordinating center PI and is the PI of one of the modeling groups. But other arrangements are really allowable with proper justification. Maybe there's a PI for a particular aim or something like that. So just justify why you're going to have the structure and why it will facilitate the better coordination of the entire grant. In terms of team leadership, although the coordinating center will provide oversight, it's expected that certain coordinating activities will be distributed across the modeling groups. So you want to describe not only the activities of the coordinating center, but also how some of the coordination activities will be shared across the modeling groups. Some examples that some comparative modeling applications can be coordinated by investigators outside the coordinating center. You might have local specialized expertise under one PI. For example, someone with specific clinical expertise, a radiologist or something like that. And those should be shared, can be shared across the groups. And even though one group would be tasked with being the coordinating center, each incubator team would be run through consensus. Next, I want to talk about professional enhancement activities for junior investigators. And we take this quite seriously in CISNET as the next generation of modelers, simulation modelers. We want to provide opportunities for them. So these we would consider pre-docs, post-docs, junior faculty. You want to describe potential activities to take advantage of the rich diversity of expertise and approaches across the CISNET consortium, including both the Incubator Program members and those funded under RFA-CA-20-043, the main CISNET program. The activities would expose junior investigators to situations that will test and improve their skills and leadership abilities, provide enhanced opportunities for professional growth, and create an atmosphere and setting conducive to learning. And then post-funding, these are ideas you're putting forward. Post-funding, you would join an already existing junior investigators committee that's been formed in the main CISNET program to implement activities. In terms of an advisory group, this would be an external panel to advise the incubator team on evolving areas of focus, and it's strongly encouraged. It's not required. And you want to outline the anticipated range of expertise and stakeholder interests, explain how input will be solicited from the advisory panel, ad hoc, relative regular teleconferences, etc. The review tells us, the NIH review tells us that please do not provide names of prospective members of the panel and do not contact such individuals prior to review. I think the why they want to do this is if everybody named a big advisory group, it might be hard to find reviewers. Next, I want to talk about two things that are a little bit similar, and I wanted to help clarify what's the difference between them, and that's model accessibility versus a resource sharing plan. Resource sharing plan, or sometimes part of that might be called the quote-unquote the data sharing plan, is not in the research strategy section and page count. So it's not in the research strategy section, and it's not included as part of the 30-page count. And these are kind of plans for your cancer site application. And components might include model documentation. CISNET has promoted certain types of model documentation called model profiles. That's more detailed documentation. And a model registry. That's model overviews. And you could read about those on the main CISNET website and get a sense of what they are. And then executable model software or model interfaces, sometimes in the form of interaction patient decision aids or policy decision tools. And then we want people to have an openness to inquiries from those outside of CISNET to pose questions or scenarios, possibly based on national or regional issues of interest amenable to modeling. And then we would want people to adhere to evolving CISNET policies regarding the transparency of models and dissemination of model results, making model runs and software accessible whenever possible to the scientific community, and releasing source code as appropriate, for example, in the context of collaborations. Model accessibility, as opposed to the resource sharing plan, are consortium-wide activities. And here we put a quote in that says, while it's recognized, this is quoting from the RFA, while it's recognized that there are no real standards for the release and accessibility of complex microsimulation models, continued thinking about barriers to accessibility and how to overcome them, and the evolving development of policies, methods, and standards for model accessibility are critically important. And CISNET is committed to the transparency of models and the dissemination of model results, model runs, and software whenever possible to the scientific community. So here, kind of like the junior investigators, you're proposing cross-consortium ideas, kind of beyond what is described in your resource sharing plan. These would be cross-consortium work group will consider ideas for implementation post-award. This group is already forming in the main CISNET group, but you would join that group and promote ideas that are done as, for example, as exemplars or ideas that would be tried across the consortium, sort of pushing the envelope in terms of what model accessibility. And the consortium, including the members funded under the main CISNET program, will be collectively working through opportunities and barriers to make models more accessible. So again, the resource sharing plan is your plan. The model accessibility is kind of consortium-wide activities that will be then brought to the main group across CISNET to try and work through. Next is subsection C, modeling groups. They're models and previous model applications. In terms of modeling groups, how will the proposed modeling groups collectively be able to conduct comparative modeling with respect to important cancer control issues and relevant priority areas for selected cancer site? Define the number and institutions of the modeling groups. Justify the number and type of modeling groups proposed. For example, the expected roles of individual modeling groups and their contributions to collectively achieve a reasonable coverage of issues relevant to a given cancer site across the cancer control spectrum. To characterize proposed groups in terms of providing conceptual and structural diversity, we don't want all the same model, as I mentioned before, as well as a range of approaches expected to enhance comparative modeling. And then summarize the accomplishments of each modeling group, and if the groups have worked together previously, their joint accomplishments. In terms of models and prior model applications, we want an overview of each model, summarizing clearly underlying model structures and assumptions, the current state of development of each model, how the model will be extended under the grant. Does the model include a natural history component? That would be expected for most models, modeling the initiation, growth, and metastatic spread of the tumor, relevant precursor lesions and biomarkers prior to and possibly after disease onset. If models don't have a natural history component are included, you would justify how they complement the suite of models and why they don't have a natural history, maybe not quite as relevant for a specific cancer. And then explain how these models complement each other in terms of providing implementations of different modeling perspectives or different ways of synthesizing available evidence. And then talk, I think, very specifically about have and will the models be developing somewhat independently. Certainly when you work together, maybe share data sources, the models kind of can come together in some respects, but we still want to maintain some sense of independence because that's the whole idea of comparative modeling, of having somewhat independently developed models. And then describe prior model applications and publications. There's some required tables for this subsection. One is model characteristics. Provide a table summarizing key model differences and similarities and stage of development. And then prior model applications. Provide a table summarizing prior model applications, referencing publications if applicable. And note that not all models will be at the stage at the start of the project where they will have developed applications. In this case, simply specify not applicable. However, if at least one model has applications, the table would be required. Applications without the required table won't be reviewed. And notice if there's somebody that applied for the RFA-CA-20-043, this table was not part of the 30-page research strategy section, while here it is. So please don't get confused about that if you applied for RFA-CA-20-043. Next is terms of proposed model development, refinement, consideration of data sources, model validation, model comparisons, model extensions, and applications. And this is really the longest section, the heart of the application where the aims are described in detail. So again, provide a coordinated plan of model development, validation, model comparisons under both hypothetical scenarios and in realistic applications, and reasonably comparative coverage of the cancer control issues amenable to modeling for the cancer site of focus. Whenever applicable, indicate the corresponding priority areas. Describe any model extensions, additional model calibration, or validation necessary to accomplish this modeling. Describe the development of any shared common inputs for the models. For example, I mentioned the smoking history generator in the lung group as an example. Describe model applications, development of user interfaces, websites, and plans to disseminate and effectively communicate the results of modeling to planners and policymakers. In terms of the timing, and there's a required table in this section, it really kind of understood that the first years of the application may focus on model development and refinement, while the later years should develop meaningful applications. And this next point is really important. If the models will be starting at various stages of development, you really need to talk about how will the timing of cross-model activities, for example, comparative modeling under both what might be called hypothetical and real applications, how will that be coordinated if they're starting at very different places? And then there's a required table. This is modeling projects. Provide a table summarizing model projects, including model development, development of data sources, common model input simulators, just for example, the smoking history generator, model validation, comparative modeling under hypothetical scenarios, and applications including items such as areas of coverage, for example, prevention, screening, treatment, and which priority areas it represents. Modeling groups included, timeline, who's going to be the coordinator, etc. And note again that in RFA 19054, this table was not part of the 30-page research strategy section. Well, here it is. In terms of budgets will vary depending on the scale of the work, and in particular, the number of modeling groups proposed. There's caps of $490,000 and $670,000 direct costs per year for 2 and 3 modeling groups, respectively. Then there's component suggested caps. You can have deviations from this. This is kind of a guideline. Try to keep to this as much as you can, but you could justify deviations. For example, in modeling groups, it's $180,000 direct costs per year per group. Maybe one modeling group won't be working on the full range of applications, and they would maybe could have a smaller budget, and some other one could maybe have a larger budget. In terms of the coordinating center, $130,000 direct costs per year, but $40,000 direct costs of that, a part of that coordinating center budget, are for contributions to cross-consortium projects providing professional enhancement activities for junior investigators. So $40,000 of the $130,000 would go to these cross-consortium junior investigators project that somebody from the group would be part of a committee to help implement. In terms of travel, generally we have 2 consortium meetings a year within the existing CISNET consortium, an annual meeting in the DC area, and a mid-year meeting at one of the sites from across the entire consortium. And they kind of have a plan to host one meeting during the 5-year funding cycle, but there's more cancer sites than 5 years, so we may or may not occur depending on the scheduling. And some of the things NCI pays for, some of the development of agendas and things like that. It's more providing local people to help us plan the meeting and to man the registration desk during the meeting, things like that. Some of the details are given in the RFA about what exactly is we need for this. In terms of the scored review criteria, it's the usual 5 areas and then 1 added area, coordinating center and program integration. And in particular, pay attention to the questions under each specific criteria to this funding announcement. They're in the RFA. And then how will the incubator program be integrated into the main CISNET program? There's going to be approximately 1-year lag in starting the funding cycle. The main CISNET program for the new funding cycle started September of 2020. We're guessing now that the new incubator program would start in September of 2021 approximately. The incubator program will share meetings with the main CISNET investigators to take advantage of experience and approaches used by current network of existing cancer sites, for example, their smoking history generator or HPV transmission models. They'll contribute to and join the CISNET Junior Investigators Program and the Model Accessibility Group, and they should designate at least 1 member to join each of these groups. The Coordinating Center PI for an incubator program is a member of the overall CISNET Steering Committee and will join that steering committee. NCI program staff, that's the NCI project scientists, will help grantees gain knowledge and access to data sources and connect them with relevant NCI consortia opportunities and priorities. And each cancer site will be assigned an NCI project scientist. Some final miscellaneous comments. Applicants are strongly encouraged to form or plan for, as appropriate, scientific collaboration as well as partnerships with policy-making entities. I think that shows a strong commitment. If you're teaming with a policy-making entity or have a letter of support, it means that your work will not just go out into the ether, but that it'll be used. That the policy-making entities will be receptive to the type of work you're doing to think about how they want to incorporate that into various screening, treatment, or other strategies. Affiliate member, these are cancer site groups can admit others who have common interests to join for specified group activities. We've had a number of successful affiliate members, but there's no funding associated with affiliate membership. These people might be funded in different ways, but want to join in, and it's the cancer site group that decides, are there enough common interests, and then you write an affiliate membership application, and then it's approved to join in with these activities. Some things that would be non-responsive, there's a longer list in the funding announcement. Of course, applications that focus on more than one cancer site, even though applications will focus on a single cancer site, some cross-cancer site work along certain themes, active surveillance, biomarkers, targeted therapy over diagnosis, will be allowed and actually encouraged. However, cross-cancer site collaborations would be dependent on other cancer sites that are funded and their interests. And applications that are focused on a very specific narrowed focus of a cancer site, say among a subpopulation or a very narrow portion of the cancer control spectrum. And applications that involve primary data collection. Generally, CISNET is using secondary analysis and use of existing data. And then questions. I think we indicated at the beginning, if you have questions that are very specific to your application, they would be better addressed by emailing me or Carol Perry. Their email addresses are at the end of the RFA. Carol Perry is for strictly financial and grants management issues. And any question with a response that is relevant to all applicants will be posted at this web link, and a recording of this webinar will be posted at the same place. And this link is available on the notice that was the notice for this webinar. So thank you, and I'd be happy to answer questions.
Thank you for a great presentation, Rocky. We'll now open it up for Q&A. As a reminder, you can type your questions into the chat and select all panelists. So to get us started, we do have one question, so I am going by how they were submitted. So the first one is...
Could we maybe I should stop sharing and we could get the panelists up?
Yeah, absolutely. We can do that. Not a problem.
Okay. So I'm going to do stop sharing. Okay. Okay.
Alrighty, there we go. Alrighty, so our first question is, can you expand on how to determine the amount of funding to reserve for junior investigators? FOA recommends up to $40K. Can you explain whether less is appropriate and when?
Yeah. So let me take a stab at that and then see if anybody else wants to. Generally, we would like people to allocate the full $40,000. That's going to be a contribution for all the different cancer sites in CISNET into joint funding. So if one group, and now there might be budget cuts and that might have an impact on things post-award, but generally we'd like to allocate the full $40,000, because if we're going to have joint activities and you contribute less, that might not, that's going to create, I think, some sensitivities and difficulties, I think. So, and we really want to promote these activities for junior investigators. They're the kind of the future of this modeling. Does anybody else want to comment on that? And this is the first, in CISNET, this is the first round where we have dedicated funding for junior investigators. In the past, we had a junior investigators program, but it didn't have any designated funding, and we really want to amp up these activities. Anybody else want to comment? So to answer quite straightforwardly, we would like you to allocate the full amount.
Great. Alrighty, so the next one we have is, any advice on human subjects research requirements, exempt, non-exempt, etc.?
Yeah, somebody might be able to answer this better than my. Generally, people do not have, PII information, and And so occasionally they do, but mostly they do not. And then, yeah, how does that, maybe somebody else wants to comment, how does that, yeah, how that translates into the designation in terms of human subjects? I think if you have just secondary use of non-identifiable information, what does that translate to? Brandy, Paul, or Jennifer?
It's for the most part exempt, Rocky. I think that you are correct. Most of the research that CISNET does is going to be considered exempt.
Alrighty, great. Not sure if we lost you, Rocky, or not. It looks like you might be having some connectivity. We did lose you for a little bit, Rocky. Just wanted to let you know we lost you for the last few seconds. Not
okay,
a problem.
and Paul, I think Paul was, before we get, Paul, were you commenting? And I think you were on mute. Do you want to say something?
Sorry, I was double muted. I was saying pretty much the same thing, Brandy, as I think pretty much exclusively people are working with de-identified secondary data, and that they generally would be classified as exempt.
Okay. And and occasionally we have exceptions to that, but generally that's the way it goes. Okay. Next question.
Perfect. Can you tell us more about topics that would be of interest for the priority area of international global health? Is this priority area of equal importance, interest as the other priority areas?
Yeah, so I would say that most of the analysis would generally be U.S. centric, but we do want to encourage people to do international modeling, and you might do countries in, could be low, middle income countries, and specifically where you're going into an area where there's an interesting difference from, say, the U.S., a very low resource area, where maybe screening has to be done, very differently, that the treatment opportunities are very limited. And then one thing that's always interesting is how do you then extrapolate from one setting internationally to another setting? Or how do you take a model that's been developed at the entire U.S. level and extrapolate to different states? And in the main CISNET program, people have done generally their modeling at the U.S. level and then tried to do maybe decision aids that are useful for states, and how do you customize models for individual states? So while a lot of the basic work would be done for the U.S., we do want to encourage people to do international modeling. So so in terms of priority areas, all the different priority areas have about the same balance. Generally, we wouldn't want somebody to say, okay, I'm just going to do all international work. I think we'd want people to do some of the work, a lot of the work in the U.S. Now, some cancer sites are of more interest in the international setting. So if you want to sort of rebalance your priority areas a little bit because of that justification, you could. That would be up to the reviewers to determine how appropriate that was. Anybody else want to add anything? Paul?
I think you came around to the point that I was going to make, Rocky, towards the end of what you were saying, in terms of some of this depends on the cancer site for which you're modeling. And it's important that there be good rationale for why you're looking at it in an international setting within your application.
Yeah, and almost every cancer site has some international applicability, but the balance, and in general, the balance across the priority areas depends on what's important for your cancer site, and then you need to justify that. Okay, can we go on to the next? Anybody else have anything to add? No. Okay, let's go on to the next question.
Awesome. How different do the models of each group within a cancer site award need to be? having common inputs suggests that there will be fairly similar structure across the models for a given cancer site.
Yeah, so sometimes, so they don't have totally common inputs, or maybe they use the inputs in different ways. Somebody might be using, if somebody might be using an input as a validation measure, while the same input for a different model would be using it as a direct model input, and so or to calibrate against. So I think you have to, so the structures of the model should be somewhat different. You have to make the case that these are not really 2 to 3 versions of the same model, and not even 2 to 3 versions of an almost the same model. There has to be some structural diversity and among the models. You don't have to. There could be inputs that are not common, only for one group, but things that are like a smoking history generator in the lung group. You know, it didn't make sense that each group would develop their own model of the U.S. population smoking histories by birth cohort. That's more of what I would call a surface parameter. Deeper natural history parameters become more and more specific to the individual model, and maybe they share common inputs and maybe they don't. Different modeling groups could have different opinions about the value of data sources, and one group could say, gee, I like this data source and I'm going to use it more extensively or exclusively, and other groups might say, well, I don't, I like a different data source. And I think the deeper you go into the model, the more different they become. Anybody else on the panelists want to comment?
So, Rafi, oh, go ahead, Jennifer.
Go, Jennifer, and then Brandy.
I think one of the things to keep in mind is that the strength of collaborative modeling is that there are differences between them, and in fact, you're using those differences to help explore with your assumptions what is actually driving changes in the results. So you want to keep that in mind as the various models are starting to develop what they want to do, that you do actually want to use those differences intelligently.
Go ahead, Brandy.
I was just going to add that on the CISNET page, you can find examples of how each of the current cancer sites do their modeling and the different types of models within each of those cancer sites. So you can see how the current funded cancer sites do this differently across the models.
And that might be in the model registry and the model profiles
Yes,
as
model
well.
Profiles.
Yeah. And just to say, sometimes when you start comparing your models, there's you're comparing when you get to real substantive applications. But before that, people have found it very useful to compare the models under simpler, more hypothetical situations that are simpler to diagnose how and why the models are different. Okay, I think we're ready for the next question. Wonderful,
and this question is referencing slide number 23. Is the junior researcher's application part of the 30 pages application?
Yes, it's part of the coordinating center, part of the application. And so you would be there proposing, and it is part of the 30 pages, and you would be proposing ideas, and then those ideas will be shared with the larger junior investigators group across all of CISNET, and then thinking about how to use that $40,000 contribution that everybody's making. And so you'll be joining an already existing group because the group has been already formed in the start of the new funding cycle, but they're going to be receptive to these, your group joining and all the innovative ideas that you bring about how to facilitate it. So the short question is yes, part of the 30 pages, and I think it's part of the coordinate. It's sort of embedded within the coordinating center section of the application. Anybody else want to add anything there?
Rocky, just the way the question is written, it appears to me as if the author of the question seems to suggest that it's an application for a specific junior investigator, and I just want to clarify that it is not a specific junior investigator. This is a program that would coordinate training for all of the junior investigators within your modeling group. So this would cover pre-docs, post-docs, and early stage investigators that work with your modeling group.
Yeah, thank you for clarifying that. Yeah, so you're not saying you have a specific junior investigator and here's what you'd like them to do. You're proposing cross-consortium ideas about how to make a program that would facilitate things for junior investigators. And I could just give one example that people have proposed. Visits to, there's quite a diversity of approaches and to modeling and so there would be opportunities for junior investigators to make short visits to other groups to learn about different approaches and things like that. And there's been a lot of nice ideas, and we're looking forward to the ideas coming from your applications. Okay, next question.
So the next question is, how developed do the models need to be by the time of application?
Yeah, so that's where maybe I should go back briefly to my slides, if that's okay. And if you could let me, Vanessa, share. And I'm going to go back to, and let me find the right slide here. Nah, that was not what I wanted to do. Sorry. Yeah, so that's why I use the word, kind of a general term, nascent. Nascent is a term that can mean many different things to many people, but we specifically explained it here. So in the context of this funding announcement, it really represents models in quite a wide range of current states of development. So that's the earliest would be just early conceptual stages, to those that have been programmed and undergoing model calibration and validation, to those that have produced published applications but could undergo extensions, expansions, reconfiguration under this FOA. Now, certainly, if you have something that it's in the earliest, very earliest stages of just a broad conceptual development, that's, it's up to the study section, of course, but that might, the thing a study section has to assess is what's the probability of success of this application. And the further you are along, the study section might feel that, I see how this model is developing, and it's enough far along that I believe it will be a success. So I think models that are in the very earliest stages of development might have some disadvantage to compare to others that are further along. But we know that for different cancer sites, modeling is in very different stages of development, and we really wanted to allow a wide range of models in terms of where they are, but probably realistically, those that are a little further along will have some advantage in the review process, because it makes it just that much easier for the reviewers to understand, where is this model, and have they thought through all of the issues? Because certainly those of you who develop models know that you make plans at the beginning, and then your plans change a lot as you go through them. And so if it's a little more mature, it probably has a little bit of advantage there. Let me stop sharing. Anybody else want to add to that? So really a wide range of, we're very open to a wide range of how developed your model is. Next question.
All right, great. So do the 40K of the 130K that are allocated for the, quote, junior investigators directly fund junior investigator efforts, or can they cover part of the senior personnel's involvement in the, quote, junior investigators program?
Yeah. So first of all, just going back to Brandy's point, it's not funding a specific junior investigator to go do something. It's not funding your junior investigator, but that money those funds are collectively the kind of the purview of this junior investigators group, this cross-court consortium junior investigators group. And they could really allocate that money in any reasonable way that they see fit. If, they wanted to, if somebody was going to develop, for example, a set of lectures and it was going to take a certain amount of time, that might be one way they'd spend a portion of the money. I think the general rule is they want to, that it still doesn't, it's $40,000 times, how many groups. And so it's a limited amount of money across all of the consortium. And you want to get the kind of biggest bang for the buck to provide very, very productive opportunities across all of the junior investigators. And there could be, pre-docs, post-docs, and junior faculty have very different needs. There might be some activities that are different that are divided up into these different groups, and some programs that might be in common. So I think it's really up to the creativity of how they want to allocate those funds. And it could be money that directly goes to junior investigators. It could be money that's paid to someone to develop a set of lectures if the group thinks that's the best way to spend the money. Again, anybody else want to comment? No. Okay. Next question.
Okay, great. Any advice on collaborating with external investigators to acquire data to be used for model development? Is there any available fund to support such collaboration?
Well, that would be part of the coordinating center funds if you wanted to do that. One thing we found is in approaching groups to get data, approaching, if you're as an individual researcher and you approach somebody, sometimes they give you data, sometimes they're reluctant. Approaching through CISNET as a whole really helps open doors to obtain data. Now, sometimes there's some fees associated with that. Those would have to be covered by the coordinating center. As necessary. One thing's nice that is that sometimes it's not just getting the data. Sometimes there has to be some analysis of data or synthesis of data to get it in a form that could be utilized for model inputs. And maybe one of the modeling groups could take that on. That's where that wouldn't necessarily have to be done by the coordinating center, but could be done by one group. I'll just give you one example. In the colorectal group, they wanted data on polyp prevalence, and there's many, many different studies of polyp prevalence of people who died of other causes, and they section their colon and look how many polyps they have. There's studies that have been done across many different years and many different U.S. and international settings. And the data are kind of a little bit all over the place. And one of the groups, not the coordinating center, did I think a kind of a Bayesian meta-analysis of these studies to get and they wanted a polyp prevalence as a function of age to be utilized by all the groups. Now, utilized probably in many different ways. So and then NCI folks know a lot. The project scientists you'll have for your particular cancer site know a lot about different data sources that may exist. Could help loop you in with other consortia, and sometimes you might have to pay for data. Other times it's a matter of providing opportunities for collaboration on papers and things like that. That if you say, gee, we want to use your data, but then it's an integral part of what we're going to be doing in terms of this modeling and this application. And would you want to be a co-author? And then that'll help us understand some of the nuances of your data. Perhaps, a collaboration in terms of publications is enough. Again, anybody want to add anything to that?
maybe just a little bit more on kind of just to emphasize that because this is a cooperative agreement, that really is in the job description of the NCI project scientist, you know, that's one of our roles, is to help facilitate those kind of connections and collaborations and give you access to resources that may be available to us at NCI.
And over time, there's been many, you know, CISNET, because of the range, because if you're going across the cancer control spectrum, there's collaborations that are facilitated across many different consortia across NCI, and so, you know, we'll help facilitate those collaborations. Sometimes it's getting data, but sometimes it's looking at modeling that might be done in collaboration with that consortia. Maybe next question.
Okay, great. And just a reminder, you can type your questions into the chat box and select all panelists, and we'll make sure to read those. So we got one more question here. What materials, if any, are allowed are in the appendix? Example, can we add technical model, detail formulas, etc.?
Does anybody, maybe I don't know the rules for that exactly. Does anybody know the rules? I thought things in the appendix, the reviewers are not required to read those, and so it put them in the appendix. I mean, you have 30 pages, so that's a fair amount, and maybe you put it in an appendix at your own risk. I don't know.
Yeah, very little is allowed in the appendix now, and this particular RFA doesn't have any different instructions for the appendix than the standard instructions, and thus we would not encourage you to put anything that you really want the reviewers to look at in the appendix.
Now, some things are not part of the 30 pages, like the resource sharing plan, so you know, that's not considered the appendix. That's just a different section. But we especially, you know, we gave you plenty of pages. You know, reading a 30-page application thoroughly is a big effort for these reviewers. So use your 30 pages. You don't have to use all the 30 pages, but use those 30 pages. And some of those tables, which we're now asking you to put into the part of the 30 pages, do summarize a lot of the issues. And so, you know, very detailed technical details. Yeah, probably, you know, they're important, but probably, you know, the reviewers are trying to get the big picture of what you're trying to do. So I think 30 pages is a lot of pages, and I think it's try to use those as efficiently as you can. Anybody else? I think that's helpful, Brandy. Okay, next question.
All righty, so we got one more question. You mentioned models can be in different stages of development. How would CISNET consider decision tools in nascent stages of development?
Not sure I totally understand that question. Maybe somebody who put that could put a little more clarification in the chat box. But I'll just, I'll just say that we're open to all models at different stages of development. I mentioned already that that models that are a little further along might have some advantage in terms of review. But certainly, if one of the models, you know, is in a very early stage of development, but the reviewers read it and they say, this looks like an interesting and very promising approach, I think it would be reviewed well. One thing we really want to keep in mind is, and we've had sometimes issues like this in the main CISNET program, if models start, if you have 3 models and one of the models is fairly far along in terms of development, and maybe say if it was 2 models and one of them is not, what plan will you have to start doing comparative modeling, both in hypothetical scenarios and real scenarios? And because one model will be ready for that maybe quickly and another one won't. And that's going to create some issues, and how you're going to deal with those issues to coordinate efforts. Anybody, was there something in the chat that just clarified it? And then I'll open it up to others.
Yes, there was. Larissa said, trying to better understand the role of decision tool development in the application.
So I'll just say, we will, and some of your aims, in the main CISNET RFA, especially in the most recent rounds, everybody was proposing very mature models. They might extend or change the model a little bit for a particular application, but they're getting into applications right away. Your aims do not have to be all about applications. Some of your early aims could be about model development and then some basic model comparisons, maybe under hypothetical situations. It's only in the later aims that you'll get to after the models are up and really functioning that you would start in your applications. Now, maybe the basic bare bones of the model will be developed, and you'll have a certain area of the model developed that you could start applications in one area right away while you work on developing other aspects of the model. So, but certainly, as you consider data sources, as you think about common inputs, for example, the example of the smoking history generator in the lung group, those could be relating to aims that are not the aims prior to the aims further on where you're actually getting into applications. We recognize that coming in, there are models at different stages of development, and we need to give time to really develop the best models possible. We do definitely want you to get to applications in the latter part of in the latter years 3, et cetera, or something in the latter as the grant progresses. And you still could be developing different parts of the model while you're doing applications in certain areas. Anybody want to add to that?
I guess,
Paul,
I'm still a little unclear about the question, but I think maybe it's worth just highlighting that these really are, you're starting with a simulation model. If some kind of decision tool came out of it, I wasn't sure if there was something in the question suggesting that it may be kind of a simpler version of a model or simpler kind of tool that could be incorporated into this, and I think the answer would be no to that. But then if
do we want to? Yeah, go ahead, Paul.
Well, I was just going to suggest that whoever asked the question, if that's worth a follow-up phone call or something, just to clarify, or if there's additional information.
Yeah, or we could have that person, if that person is willing, we could elevate that person and they could say something verbally, just so we understand the nuance of the question. And then also, anybody is welcome to email me to think about a phone call on specific questions. But did we answer that question, who was ever asking it, and would they like to, we could elevate them and so allow them to make any more clarifications? Okay, fine for now. And Paul, I'm not sure I understood I didn't understand your answer totally. Maybe just say a little more about what you were saying, and say a little more about it. That if they were doing a decision, I mean, go ahead.
So I was reading that as possibly thinking about it being kind of a simpler kind of decision tool that wasn't based on a simulation model. It was just a development to help somebody make a decision about a potential intervention, but not necessarily a kind of a full simulation model. And I would say that would not be in scope. That's what I was saying, if that was the suggestion, but I wasn't sure if that's what it was.
Yeah, we have modelers in CISNET develop, to help with their big model, have developed smaller models to help understand one aspect of the modeling in a simpler context, and then that feeds into the knowledge for the bigger model. But just to develop simple little decision tools, yeah, that's not, you're here developing a sort of a bigger model that's across the cancer control spectrum, and we call that a decision tool. There's all kinds of decision tools, but these are decision tools that'll have, sorry, I think I need a drink of water, that will have, prevention aspects, screening, treatment, to the extent that they're applicable for your cancer site, that'll be doing multiple birth cohorts. So probably a pretty big, eventually a pretty big complex model. You could have some simplified version of that, that might be, or maybe an interface related to that won't expose all of the parameters, especially some of the deeper natural history parameters that could be used by local state and local cancer control planners. But generally, everything is focused on this one sort of larger, but one for each 2 to 3 across the cancer site, pretty larger comprehensive models. You can do smaller models kind of on the side in support of that. So that's, but if you're just going to be, we're not about develop. I think you're right, Paul. It's not out of scope to just develop a bunch of small little individual decision tools that are not sort of linked. Is that what you were saying? Yes.
Yeah.
Because that then doesn't incorporate the synergies between all these different types of interventions, and that's what we're about. That's kind of what I call one-off models.
Yeah.
So, okay, any other questions?
We have no more questions coming in right now. We do have some time left, so if folks want to submit those questions via chat, we can definitely answer those. But if we don't, we can just wait a few seconds. But if we don't, Rocky, you're more than welcome to say some final remarks, and then I can close out the meeting. Okay. Yeah, I'll make a few slightly extended remarks to give people time to ask some final questions. But thanks first of all, for the very, very good questions. We're very excited to have a robust group of applications across many interesting cancer sites, probably ones that we thought of and ones that we didn't think of. Again, if you want to know things that are kind of related to your specific applications, they're very specific to your application, then you're welcome to email me to have a call, and we'll try to do as many of those as possible. Other than that, any other panelists want to comment on anything? We think that the synergies that are going to be between the main CISNET program and the Incubator program are going to be interesting and exciting. It's going to kind of bring a whole new dimension and a bunch of new modelers into the CISNET orbit, and we really value having CISNET being a community of modelers. I didn't mention, but I will mention that one tradition in CISNET is having different CISNET dinners sponsored by one of the cancer site groups, but then of course everybody is welcome across the meeting. So be thinking about what kind of food you like. Which sites are not allowed? Yeah, so Ellen Richmond saying, so the cancer sites that are not allowed, I don't know if you missed that earlier, Ellen, are the 6 cancer sites that have previously been part of CISNET: breast, prostate, colorectal, lung, esophagus, and cervical. Anything else? Did we get any other questions while I was saying all that, Vanessa? No, we did not. We did not get any questions.
Okay. Well, thank you again. We look forward to your applications. Please send a letter of intent. It really helps us. They're not required, but it really helps us. It's just a short letter that says a few basics as specified. And
great.
Thank you, everybody.
Yes, thank you to our audience and our presenters for a great Q&A. As I mentioned earlier, this recording will be archived for a later viewing. Please feel free to continue the conversation via email if you have additional questions that were not answered during today's presentation. And thank you again for your participation.
Thank you, and goodbye.